So welcome in this session. This is very useful session. Uh, this session is completely meant for yourself. Probably patient has nothing to do with this session. Whatever you will learn, it's for your own safety, your own benefit in future. So before I move ahead with the needle-stick injury, a line about prophylaxis. That what is prophylaxis? It is basically the treatment or the any kind of vaccine or action taken to prevent a disease. Means not for treatment of the disease has not been established, but we are trying to prevent it. It can be pre-exposure prophylaxis if we are taking the measures before the exposure has happened. Please mind, it is before the exposure has happened, it is not before the disease has happened. There is a difference between the exposure and the disease. And if we are taking the measure after exposure has happened, this is post-exposure prophylaxis. And our today's topic of needle-stick injury comes in this section of post-exposure prophylaxis, because with needle-stick injury, exposure has already happened. So don't get confused that we are going to talk about the treatment about hepatitis or HIV, which can happen after needle-stick injury. We are going to talk about the prophylaxis so that infection should not set in. Right. So I have broken my entire talk in small pieces to give you few very clear messages, right? The first message is what is exposure, how to define an exposure. The external surface of human body can have only skin and mucosa, and it can be exposed to patient blood, tissue, body fluid, or percutaneous exposure. I have put in 1 star and 2 star, which means skin, if it is non-intact skin, then it is a exposure. Non-intact skin means is if there is any deceased portion of skin, means skin with psoriasis, ulcer, erythema, because in all this condition where like psoriasis or erythema is there, the vascular supply of the skin is increased. So if the exposure happens, there is high chance that pathogen can enter into the circulation. Then body fluid. All the body fluids are not considered as infectious. Like any body fluid other than feces, nasal secretion, saliva, sputum, sweat, tears, urine and vomitus. If anything other than these body fluids coming in contact with mucosa or non-intact skin, it should be considered as exposure. Please mind what I have told. Body fluid other than these things, these apply to the infections which we are usually concerned at the time of needle-stick injury. That is hepatitis B, hepatitis C, and HIV. So if there is a contact of mucosa with blood, it is exposure. If there is contact of mucosa with tissue, percutaneous exposure is anyway, it's an exposure. So you can understand what is exposure and what is not an exposure. There can be an accident, but necessarily not an exposure. Another piece of information which I want to pass on is who are at risk of needle-stick injury exposure, why, and how much. Means what could be the sources. Among the needle-stick injury, among the various sources of exposure, if you see, needle-stick injury or percutaneous exposure is the most common type. I understand that this data could also be a biased data, because whenever a person is having needle-stick injury, a panic is created, and most of the time it is a needle-stick injury which is reported, but any other exposure which is not due to needle injury is not reported. So it could be the representation of over reporting of needle-stick injury. Among the various percutaneous sources, hollow bore needle is the most common source, because obviously this is the one common instrument which we are using for blood sampling, for injections. So that is why hollow bore needle is the most common source for percutaneous injury, followed by other things. And the most common procedures which lead to needle stick injury are intramuscular or subcutaneous injections, or at the time of drawing blood sample. And again, these are the most common procedures actually which are done. So this is that's why they are overrepresented. This is a bit of theory, but what message we should have, that the needle stick injury are the most common source for percutaneous exposure. Among needle stick injury, if you see, or percutaneous instrument, hollow bore needle are the most common source, and the most common procedures are injections or blood sampling. Then who are at risk? The winner is our staff nurses, right? This is the global data. Because most of the healthcare, especially the countries which provided all this kind of data, means developed country, are provided by the staff nurse, not by the physician or by the lab assistant or the laboratory person. And that is why nurses are at the highest risk of needle stick injury. So it is the marker that who is providing the maximum health care. In your setting, if doctor is the one, when I was in my post-graduation, doctor was providing maximum health care, starting from fluid change, blood sampling, cannula placement, RT placement, even enema administration, all those things. So in that situation, probably the doctors are at the highest risk, right? But this is the global data. So if we know that needle stick injury can happen, so how to avoid these needle stick injury? Before we learn that how to prevent uh, hepatitis infection following needle stick injury, it's very important to know how we can avoid, what are the common mistakes which lead to needle stick injury. These are the few mistakes which are avoidable, and these are the common humor errors which I have converted into humorous error, so that you can say it's easy to remember. Avoid multitasking. In present era, we are fond of doing multitasking. We might be talking on one phone, second phone, doing some procedure, thinking about home, and reading novel, so many things. But it is not good, at least in healthcare setting, where the risk is not only limited to the patient, but also to the healthcare worker, and it's a matter of life and death. So multitasking is one of the reasons which we should avoid in our workplace. When we are doing our work, we should concentrate in our work. A small mistake in our concentration can lead to a big needle stick injury, exposure, life threatening condition, anything can happen. So we have to concentrate in our work. Then avoid hurry. Many times we are in hurry that we have to leave for home, we have to take care of some other things, and this hurriness we might save 5 minutes, 2 minutes, but it can put you in a big trouble if a needle stick injury happens or some other kind of accident happens. So avoid hurry. And the most the biggest menace of the present era is the mobile phone, which can put you anywhere if you are not cautious while using it. Now the second piece of information which I want to pass on, share with you, is the risk of transmission following needle stick injury. Whenever needle stick injury happens, the first thing which comes in our mind is the possibility for HIV infection. But we hardly think that any other infection can also be transmitted, especially hepatitis B and C. I will give you a small mathematical calculation that whenever there is a needle stick injury or any other kind of exposure, the risk of transmission depends upon two factors. One, the disease prevalence in the source population, and second, transmission rate following exposure. Let us do a small bit of mathematics. This is what I have written in previous slide. The transmission risk is equal to prevalence multiplied by transmission rate. Suppose we are talking about a disease Z, and the prevalence in general population is 5%, which is written as proportion 1. Transmission following exposure, possibility of transmission is 10%, which is again proportion 2. then transmission risk is equal to 0.5%. Is it clear to everyone? Because this is very important point, that what is the risk of transmission following an exposure for hepatitis B, C or HIV. This slide should be clear. And this is the disease burden in our country. Hepatitis B, 30 million people are infected with hepatitis B. 10 million people are infected with HCV and 3 million people are infected with HIV in our country. This is the Indian data. So if you take HIV as a baseline, 3 times of HIV are HCV and 10 times of HIV are HBV in our country. So disease burden for HBV is 10 times as compared to HIV, and disease burden of HCV is 3 times as compared to HIV. Transmission rate following exposure, that if you know that the person was HBsAg positive and you are exposed, then the risk of transmission is 30% on average for hepatitis B, 3% for HCV, and 0.3 is for HIV. Again, you can say risk of transmission for HBV is 100 times as compared to HIV, and for HCV it is 10 times as compared to HIV. If you multiply them, following a needle stick injury, you have 1000 times more risk of HBV transmission and 30 times more risk of HCV transmission than HIV transmission. But whenever there is a needle stick injury, the first thought which comes in mind is HIV. And as a hepatologist, I can tell you, hepatitis B is not less lethal than HIV on global map. It is not less debilitating than HIV. Actually, if you see the global data, the number of deaths which is happening due to hepatitis B and C in the world is continuously increasing, but the death due to HIV, tuberculosis and malaria, they are decreasing. And death due to HBV, HCV are more than the combined death caused by HIV, tuberculosis and malaria. So in my opinion, HIV has got much more importance and resources, and also our concern in any situation, especially needle stick injury exposure, than hepatitis B and C. We must be more cautious about exposure to hepatitis B and C. Now coming to the crux of the talk of needle stick injury management. If unfortunately any one of us is exposed to needle injury, we have to take 3 steps. First, local management, wound management, then report the incidents. Ideally, there should be a reporting point. Earlier, we had hepatitis prevention and control cell in our gastroenterology OPD before COVID era. And at that time, all those with needle injury were coming there and a form was filled. All the reporting was done, but now it is stopped. Then the third point is the specific care following hepatitis B, C or HIV exposure. HIV I am not going to deal because I am not the right person to talk about HIV. B and C I will restrict myself. So wound management, we have to clean the wound with soap and water. Flush mucous membrane with water. Don't use soap or any other antiseptic on the mucous membrane. And there is no benefit of using antiseptic or disinfectant. There is no benefit of squeezing or milking at the site of puncture. Rather, it may increase the risk of transmission. Because whenever you are doing squeezing or milking, the blood supply to that region is increased. And whatever virus has gone in, you cannot bring it out just by milking. It would have gone in, would stick to some of the tissue, and then the blood which has pooled there will carry it along and circulate to the body, right? And avoid the bleaching and other agents. So this is the reporting I told, that we were recording all this data when any needle stick injury is done. About the accident detail, date and time of exposure and what procedure was done, where it was done, what and actually what event happened, verbatim. Exposure detail means the route, percutaneous, mucous membrane, skin. If it is needle, then what is the size of needle, whether there was a ooze after needle stick injury or not, and what is the serological status of the source person and the serological status of the exposed person, because it will guide us about the, at least anticipating the prognosis and the management of the patient, and sometimes medical legal issue also. Whenever we are evaluating our source, we have to take informed consent that needleistic injury exposure has happened from your blood and we want to investigate you. Means we cannot force a source patient to undergo any kind of investigation. This is according to law. We have to request him and we should not make him to pay for it. I know in our hospital it is practically not possible. At least we should not force him, and we have to see the financial condition of the patient. And also the confidentiality of the source person should not be exposed everywhere, which is true for any patient, and we all know how much we are practicing in our country. Care of the exposed person, we have to test the exposed person as soon as possible for HBsAg, NTSCV, HIV and ALT, means SGPT, and advise him to refrain from donating blood, plasma, organ, tissue or semen. But we should not ask them to modify the sexual practices, avoid pregnancy, discontinue breastfeeding or modify the professional activities. So these are the very important points, because whenever a person is exposed, he or she will have 20 questions and you will get their answers in this slide. There are no guidelines which suggest that we have to advise the person to avoid pregnancy or to discontinue breastfeeding or to modify the professional activities. So we have covered the local care, reporting, and now coming to the specific care. Suppose the exposure has happened with hepatitis C virus positive patient. Before I move ahead with the slide, let me inform you that in present era, hepatitis C virus treatment is very simple, not very simple, it is extremely simple. The government of India has launched a program which is called as National Viral Hepatitis Control Program. And the objective of the program is to decentralize the hepatitis C virus treatment services to the sub-center level. So you can understand how simple it is in present era to treat hepatitis C virus infection. Right, so if anyone is exposed to HCV, baseline investigation is done as we have learned, then no medication, no precaution, nothing. After 6 weeks, again test for ALT. At 24-week, test for NTSCV. If cost is not a problem and patient is of too much concern, then at 12-week you can test for SCV RNA. But please mind, SCV RNA is very costly. In open market, it costs something around 3,000 to 5,000 rupees. And anyway, if the person is found to be positive, you have to wait for next 6 months. So I will suggest only at 6-week test for ALT, because if ALT starts showing rising, it is increased by 3-fold from the baseline. That means the infection has set in. But many infection, 25 to 40% of HCV infection clears naturally. So we have to wait, and after 6 months, we have to test for NTSCV. If person is seroconverted, then we have to test for RNA and other things, treatment. And the same protocol follows for HBV also, but you have to do HBV DNA at 12 weeks instead of HCV RNA. For hepatitis B, we have 2 options. One is vaccine, second is immunoglobulin. And vaccine provides active immunity, immunoglobulin provides passive immunity. When we are giving vaccine, usual dose schedule is 0, 1, 6, 3 doses, 1 ml and 2 ml intramuscularly. And after 3 doses, 4 weeks after 3 doses, we are checking anti-HBs titer. If it is more than 10 milli international unit per ml, we consider that the person is protected, and we need not to repeat the titer, or we need not to give any booster doses of hepatitis B vaccine in future. Even if you keep on monitoring titers, it will become undetectable after a year or 2 or 3 years, but it doesn't mean that the person is susceptible to HBV infection. We all know, we all are doctor, we know that there the memory cells are formed, and as soon as if you have exposure, that memory cell will wake up and will form antibody even before the infection is set in, and this anamnestic reaction will take care of your exposure. So there's no need for repeated anti-HBs titer measurement, and there's no need for booster doses. Rather, if you keep on testing anti-HBs titer, the fact is that after 40 years of age, titer will go down, and you will be caught in a vicious cycle of anxiety and non-responder. Because naturally after 40 years of age, your immunity will go down, means not the immunity, but your titer will go down. You will again take a vaccine, but vaccine will not show that much of response. You now think that now I am non-responder, and with every exposure you will keep on taking immunoglobulin, and we all know that any immunoglobulin which is not developed in human being, when given to human, carries their inherent risk of reactions. Unfortunately, if anyone develop hepatitis B infection, they will develop acute hepatitis B, and 95% of those with acute hepatitis B recovers completely without any problem, and HbA1c is also cleared. This is the efficacy of post-exposure prophylaxis. If we are giving only vaccine or immunoglobulin, and you can see that the addition of immunoglobulin gives you 5 to 10% of benefit. It is not of much of benefit actually. And the dose of immunoglobulin is 0.06 ml per kg. For adult, it comes roughly 5 ml. 5 ml is a big volume, so it has to be given in gluteal muscles, because only those in 2 equal halves, because those muscles can accommodate this much volume. Other places it will be difficult. So that was a theoretical part. Suppose a person is coming to you that he is exposed to needle-stick injury. What you do? Your first question you have to ask, what is the vaccination status? And there are two possibilities. You will get answered that I am vaccinated or I am not vaccinated. If he says or she says that yes, I am vaccinated, then second question has to be, what is the anti-HBs titer? Whether it was tested ever, if it was tested, what was the level? And these are the three possible answers you are going to know. The person may say that yes, it was tested and it was less than 10. The second answer could be it was tested and it was more than 10. And third could be I don't know. It was never tested. It was tested, but I don't remember the value. So I will take all this scenario one by one. If anti-HBs titer was more than 10, need not to do anything. No vaccine, no immunoglobulin, no additional precaution, nothing. Nothing is going to happen. If it was less than 10, then you have to give vaccine plus 1 dose of immunoglobulin, or you have to give 2 doses of immunoglobulin at the interval of 4 weeks. There are two options now. Obviously, the first option is cheaper and more effective. Then why I have given you the second option? This is very important point. The second option is only for those who are known to be non-responder to the vaccine. And the non-responder definition is the person should have not responded to full 2 courses of 3-dose vaccine schedule. But usually people are given one schedule of 3 doses, not the 2 doses, 2 courses. So if anyone who has not responded earlier to 2 courses of 3-dose schedule will be considered as non-responder, and that person has to be protected with 2 doses of immunoglobulin to be given at the interval of 4 weeks. I think I would have made it clear to everyone. Now the third option, that anti-HBs titer was not tested, or it was tested but I don't know the value. then you have to give, you can go for anti-HBs titer testing if it is available, and you get the result, and accordingly you can respond. If you don't have option to get tested, then obviously you can choose this option, vaccine plus 1 dose of immunoglobulin. If a person was not vaccinated, then obviously you have to start 3-dose schedule of vaccination plus 1 dose of immunoglobulin. So in summary, risk of transmission following needle stick injury is maximum for hepatitis B, followed by hepatitis C and HIV. Post-exposure prophylaxis is available for HBV and HIV, but there is no measure to prevent HCV transmission following exposure. For HCV, most of the acute hepatitis B clears, which can develop after HBV exposure, and anti-HB titer more than 10 milli-international unit per ml is protective. No booster are needed in follow-up. So if there is any question, I am ready to answer.